Thank you so much for the organizing committee to invite me to give this lecture. However, 15 minutes lecture to talk about stone, it's like you are asking me to talk about nephrotic syndrome in 15 minutes. So it's very hard, but I'm going to try to just summarize and give you some highlights how to treat kidney stones medically. First of all, we have to understand that kidney stones is not a surgical problem, but it's rather mainly a medical issue. So it's a chronic metabolic condition interrupted by symptomatic preventable stone events. So it's like you're preventing heart attack or you are preventing DKA in diabetic patients. So this kind of metabolic condition, especially in patients with recurrent kidney stone, we need to understand exactly what is the pathogenesis, why this patient forms stone, to prevent them from further stone formations. So this acute events when they have this kidney stone pain or hematuria or symptoms, there is a substantial future chances that they can develop other medical conditions, especially osteoporosis, obesity, cardiovascular disease, and chronic kidney disease as well. So the medical treatment of kidney stones is primarily aimed to optimize the metabolic factors and reduce the urinary supersaturation of stone components, which is actually the most commonly the calcium, the oxalate, the phosphate. So, by the way, kidney stone affects about 1 to 3% of all of our adult population, and all of us should have about 20% chance of developing at least one renal stone during our lifetime. And if you have one kidney stone in the past, probably you will have about 10-15% chance of developing another kidney stone in a year. And more than 50% of those who formed a stone in the past will have another kidney stone in 5 years. And in 10 years, the chance will be about 70 to 80%. And almost everyone who had a stone about 15 to 20 years ago is going to form another stone. Of course, if you are doing preventive medicine, the chance will be less. Again, the other problem that we are seeing nowadays is in the past, men to woman ratio is very high when it comes to stone formation, but among women, the prevalence has increased by about 75%, and now about 40% of stone formers are women. So also there is very good correlation between stone and obesity, stone and weight gain, especially in women rather than men. Who develop kidney stone? You see among all profession, you can see soldiers, lifeguards, marathon runners, they have high chance of forming stones, probably because they are living in outdoors and have some kind of hypovolemia or dehydration or concentrated urine, but also surgeons are at a higher risk. Teachers also have a higher risk. So also people who live in temperate area in warmer climate, they have higher chance of developing kidney stone rather than patients with less insensible fluid loss in the cold areas. So the most common type of kidney stone is the calcium oxalate stone, about 26%, followed by calcium oxalate and calcium phosphate stone. So both calcium oxalate, calcium phosphate are about, more than 50% to 60%. If you include the calcium phosphate, this will go up to about more than 60%. Steroid stone is in about 20%, and uric acid is not very common, about 5 to 8%. Of course, cystine stone is very rare in adults. However, it might be more common in children. So again, 70% of kidney stones are calcium containing, and about 30% has phosphate in it. So we need to screen certain population. And if you have kidney stone, you need, of course, to check the family history of kidney stone, the dietary habit of these patients, and also check if this patient have any medical conditions that might increase the risk of kidney stone, like GI disease that can increase hyperoxaluria, bone disease because of the association between the bone loss and the kidney stones, also because of the hypercalciuria, gout, because not only of the uric acid stone, but also it increases the chance of calcium oxalate stones, type 2 diabetics, obesity, recurrent UTI. Then we need to do a basic metabolic profile focusing on sodium, potassium, chloride, bicarb, BUN, creatine, and glucose, and we'll come back to this in a minute. Calcium, uric acid, IPTH to make sure that this patient doesn't have hyperparathyroidism, even if the patient is not hypercalcemic, because there is eucalcemic hyperparathyroidism. Then we need to check the urine, especially the urine pH and crystals, and if there is any infection, especially with the urea splitting organism. So again, we need to check the serum for the kidney function, for the bicarb. We need to check the urine, and we need also to look to the urine visually and physically. So if you can see here, this urine has it's very diluted, and this patient has very low chance of forming another stone, while this patient with very dark concentrated urine have very high chance of recurrent kidney stone. Also, the urine specific gravity, because some stone, they like to precipitate in alkaline urine and other in acidic urine, as I'm going to show you. The urine pH for the urine acidity and the alkaline urine, the urine specific gravity for the concentrated or diluted urine, and the urine crystals. Again, urine crystals is very important, and urine analysis, and we encourage all nephrologists to look at their patient's urine, because it's actually a kind of liquid kidney biopsy. So don't forget this tool. This article was published last month, so I really encourage everyone to read it. So let us just see what kind of crystals we have here. This is a dumbbell-shaped crystal, which is typical to the calcium monohydrate. And this is an envelope-like crystal, which is calcium dihydrates. And this is a coffin lid-shaped style, which is typical for phosphate crystal. This is very typical for uric acid crystal, which is either rhomboid or diamond shaped. And this is very typical for cystine crystals, which is hexagonal. So if you like to remember things with using mnemonics, you can say calcium oxalate, which is the most common kind of stone, is looks like an envelope. Cystine is cystine for six, so it's a hexagonal. Uric acid is rhomboid, and strovite is a coffin-like. Again, these kind of crystals is not only important for stone formation, but also it's important to manage because of the crystalline nephropathy. So this patient can have some kind of CKD in the future because of the precipitation of these crystals in the renal tubules that can induce inflammation and tuberointerstitial chronic kidney disease in the future. Who needs to get a metabolic workup for kidney stone? Any patients with recurrent kidney stone, or patients in their first attack of kidney stone, if they have multiple kidney stone, positive family history, solitary kidney, or children, and anyone who is interested to get a metabolic profile. Again, also patients with underlying medical condition like metabolic syndrome, malabsorption, primary hyperpara, bone disease, RTA, sarcoidosis, recurrent UTI. These patients are eligible for metabolic workup. And what we do is we collect the urine for 24 hours and we send it to LithoLink. And this is what we are actually checking. The first most important thing is the urine volume. So we encourage any patients with a history of kidney stone to have at least 2.5 liters of urine daily. This means that he or she need to drink more water. Then we examine the crystal supersaturation with calcium oxalate and also with calcium phosphate, the 24-hour urine calcium, because hypercalciuria is the most important factor in stone formation, and also the 24-hour citrate, because hypocitraturia is one of the most common causes of stone formation, because citrate is a very potent inhibitor of crystallization. Urine pH and uric acid in the urine 24-hour. And we check also the urinary sodium in the 24-hour, because this is the reason that we can know exactly how much salt the patient is getting. So patients who are eating high salt diet or adding more salt on their food, they have hypercalciuria and higher chance of developing kidney stone. 24-hour urinary creatinine, just to make sure that this patient is not overestimating or underestimating their urine collection. So again, very important, especially the urine volume and the calcium and citrate, and also the oxalate, because calcium oxalate is the most common cause of stone diseases. So they give you this kind of shades. So this patient, for example, have hypocitraturia. So here is in the red. So this is a high risk of calcium stone formation. So if you move from the green to the red, this means that you're moving to the wrong direction. And here, this is repeated urine collection. You can see the 24-hour urine creatinine is almost the same. This means that this patient urine collection for 24 hours is mostly accurate, despite one time he has very low urinary output, but it turned out to be accurate. So we highly encourage this patient to increase fluid intake. So this patient in the past, when he came in with a stone, he wasn't drinking well, and now he's drinking well and making more than 2 liters of urine. His citrate actually has increased from 280 to 549 with potassium citrate. So that's another good parameter. And also his urine pH has increased from 5.6 to 6.4. So this is going to decrease the chance of recurrent calcium oxalate stones. So to prevent further stone formation, the first most important step is to increase fluid intake, water intake, and I'm going to show you that there is evidence from several studies that increasing the urinary output probably is going to decrease the stone recurrence maybe by about 70-75%. The other most important risk factor for stone formation is hypercalciuria. So if you have calcium excretion more than 300 milligram a day, your risk of stone formation goes up maybe to 4 or 5 folds. So again, there is also very good correlation between urinary sodium excretion and urinary calcium excretion. So if you are taking more salt, you are excreting more sodium in the urine, and at the same time, you are excreting more calcium. So your chance of having stone malformation will be higher. Also, the protein intake, a patient with more than 2 gram per kilogram of protein, they would have more hypercalciuria, more uric acid excretion in their urine, and their urinary citrate will be less. So they have higher chance of having recurrent kidney stone. Idiopathic hypercalciuria is one of the most important factors for stone formation. So please maintain urine output more than 2.5 liter a day. Sometimes we use thiazide diuretics because, as you know, thiazide diuretics decrease the renal tubular excretion of calcium. And as you know, loop diuretic actually increase. So we try to avoid loop diuretic and use thiazide diuretic. potassium citrate, because citrate, as we discussed, is a major crystal inhibitors. So we try to give citrate, and also because citrate will alkaline the urine, so will decrease the chance of calcium oxalate stones in the future. Sodium restriction to 2 to 3 grams a day, and protein moderation to 0.8 to 1 gram per kilogram per day. Urine pH is important because acidic urine is bad for the calcium oxalate stone, and alkaline urine is very beneficial in uric acid stone and cystine stones. So again, hypocystaturia, especially in women, is common and is a big risk factor for recurrent kidney stones. It could be either idiopathic or secondary, and also acidosis reduce the urinary citrate by increasing tubular reabsorption. So we try to avoid having acidosis. So citrate, again, is a most powerful inhibitor of calcium oxalate stone formation, and hypocystaturia could be idiopathic or could be related to increased protein intake, RTA, any kind of acidosis from diarrhea or malabsorption. And also you need to remember that hypokalemia, increased ammonia genesis, and this ammonia genesis will also induce hypocystaturia. How to improve the urinary citrate? We advise our patients to drink more soda, especially lemonade, and it has to be fructose free fluid, and we encourage them either to drink that 7-Up, or Sprite or Canada Dry, and try to avoid any dark like Pepsi or Coca-Cola, soft drinks, because they have oxalate. And also we try to avoid any fructose or glucose enriched fluid, because also this increase the urinary sodium excretion and urinary calcium excretion. So again, having a good dietary history, and advise the patient to decrease the salt intake and to decrease fructose intake and increase fluid intake is very essential. So again, hyperoxaluria also is one of the most common precipitant factors for recurrent calcium oxalate stones. So need to avoid or encourage our patient to avoid spinach, chocolate, beets, peanuts that can increase the absorption of oxalate from 5% to 25 to 50%. Treatment of hyperoxaluria, you need to decrease dietary oxalate and fat. We can use oral calcium supplementation, but not too much. Cholestyramine, again, increase fluid intake, and oral citrate. Hyperuricemia, actually the most common cause of renal stones in patients with hyperoxaluria and gout, still calcium oxalate stone. So the uric acid acts as amidus for calcium oxalate stone, but uric acid stone itself is rare, as we discussed, and the uric acid stone is particularly radiolucent and dissolve in alkali media. So alkalinization of urine is very important. Increase fluid intake, decrease purine diet, and we can use allopurinol not to decrease mainly the serum uric acid, but to decrease the hyperuricemia. So also we need to be aware of the calcium phosphate stones that is very pH dependent, precipitate in high pH. So if you have a calcium phosphate, you need to acidify, not to alkalinize the urine. It's common in patients with metabolic disorder like hyperbara or distal RTA, or with recurrent urine infection. It's often bilateral and frequently recurring, and can be associated with nephrocalcinosis and kidney dysfunction and CKD. Struvite stone that has three components. It has magnesium, ammonium, and phosphate. It's more common in women, and it causes staghorn stone, and it grows very rapidly and can be associated with severe urosepsis, pyelonephritis, and kidney failure as well. Here is the staghorn stone bilateral, and this struvite stone is caused by the urease splitting organism like Proteus, Klebsiella, Pseudomonas, or Serratia. E. coli, which is the most common cause of urine infection, is not urease splitting, so it's not associated with struvite stone. Treatment of struvite stone, we need to remove this staghorn stones. We need to control the infection. Sometimes we use antibiotic for a long period of time. And acetohydroxymic acid is a urease inhibitor, so we can use it. And also we need to avoid alkalizing the urine. So we need to motivate our patient to dilute the urine through drinking more amount of fluids, use thermos, then they can put ice water or cold water, or can put water in the freezer and have it during their activities or outdoor activities. Also, we need to have some print out, some instruction to give to our patient either electronically, so some resources, or print out. The medical expulsive therapy is very important. Tamsulosin, also the alpha blocker, the calcium channel blocker, and also, several other studies even showed that steroids in the acute phase can decrease the inflammation if you can give it for 7 days, and decrease the chance of further stone formation and help for stone passage. So the worst kind of pain is the kidney stones. Try to avoid having this for yourself or for your patients. Again, all of this information has no value except we put it in practice, and we try to improve our patient outcome, and we try to improve our clinical practice. And with that, thank you so much. And again, thank you for inviting me to give this quick